This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, this is Halley Alexander, and today I'm here with two guests. I have Genevieve Rayner and Eliza Honybun from the University of Melbourne School of Psychological Sciences. We're going to discuss their recent review article examining neurodevelopmental and functional outcomes of in utero exposure to anti-seizure medications. This is a field with growing information as we continue to learn more about outcomes and continue adding new anti-seizure medications into the mix. And it's my understanding that the American Academy of Neurology guidelines are in the process of being updated, but the last published guidelines are from 2009. So Genevieve and Eliza, I'm really excited to see how your research may impact our clinical practice.
Thanks so much for having us, Halley.
So Genevieve, can you start by just telling us what new information does this study provide that we don't already know from some similar studies that have been done, such as the MONEED studies, which that's the maternal outcomes and neurodevelopmental effects of anti-epileptic drugs?
Yeah, as you say, the MONEED study, which is led by Kimford Meadow out at Stanford University, has really been at the forefront of an increasing number of studies around the world that are examining this issue of what are the adverse effects of anti-seizure medications for the offspring of women with epilepsy. And as you know, in our patient care of women with epilepsy, a lot of them are of childbearing age. And so it's an issue that comes up a lot in discussions with patients around what the best medical regimen might be for them. So although MONEED and similar studies in the UK and Ireland, North America and the Australian Pregnancy Registry have been fabulous in bringing out an increasing number of studies looking at this issue, what my PhD student Eliza here did, who really brought together these 43 studies of the systematic review, was to take a high-level look at across all these diverse studies to crystallise what the key signal that we're getting from these studies across these diverse methodologies and populations, what are the key findings in terms of the neurodevelopmental, but also the cognitive and adaptive functioning outcomes that these medications, including newer generation medications, might have on the offspring of women with epilepsy. Eliza, did you want to talk around the specifics of what the systematic review was able to look at?
Like you mentioned earlier, Halley, there's newer drugs coming on the market all the time. So this is an area that is continually evolving. So I think there's value of a systematic review at this time point to come in and synthesize different populations together with studies that are conducted during different time points. For example, in this review, we have data from infancy through to adolescence, and this allows us to see the evolution of these neurodevelopmental effects over the lifespan. So we can sort of better understand the neurodevelopmental sequelae of this. And it also gives us the opportunity to critically examine the strength of the literature to sort of tailor clinical practice and also sort of change our methodologies of these studies going forward to address some of the methodological limitations, because this area of research is challenging to conduct. So I think overall, a systematic review allows clinicians to get a clearer picture of the different types of risks. And this review examines different domains of neurodevelopment. So for example, we look at specific traits and behaviours, sort of symptom-based measures of functioning together with prevalence estimates of neurodevelopmental disorders. And I think this approach expands beyond just a categorical diagnosis of autism spectrum disorder or ADHD. And there's value in giving attention to clinical and symptom level data that's routinely collected as part of these studies, but really seldom scrutinised in detail. So we can look at sub-threshold traits, for example, and behaviours that perhaps don't meet diagnostic criteria for a DSM-5 disorder like autism, but these are still things that can have a functional impact on a child and impair their learning, their social skills, their behaviour. So I think overall this review was aimed at establishing a richer clinical picture of these effects to enable comprehensive clinical phenotype and apply across a broader spectrum of offspring exposed to anti-seizure medications in utero.
And so what did you find in your review?
So like Jen mentioned, we found 43 studies, and, while we've known for a while that valproate carries an elevated risk, this review again emphasised that it poses the greatest risk of adverse outcomes, including an increased risk of autism spectrum disorder, intellectual disability, as well as poor adaptive functioning. I think there's growing evidence now that indicates topiramate also carries an elevated risk. In this review, we identified that there was a 2-fold increased risk of autism spectrum disorder and a 3- to 4-fold increased risk of intellectual disability amongst offspring that were exposed to topiramate in utero. And similar to valproate, the risks associated with topiramate appear to be dose dependent, whereby exposure to higher doses of topiramate is associated with the greatest risk of adverse outcomes. Looking towards more of the positive side, lamotrigine continues to be one of the safer choices for women of childbearing age, with the neurodevelopmental outcomes of these offspring comparable to unexposed children. And then the majority of evidence to date regarding levetiracetam indicated that it was of a low risk of adverse outcomes, but there was a recent study that identified an increased risk of ADHD and anxiety disorder, but this requires replication, as we sort of discuss in our review. And then there was sort of a mixed bag with some of the medications. For example, with phenobarbital and carbamazepine, there were some reported adverse neurodevelopmental effects, but the evidence for these was either quite limited in terms of either small numbers of offspring or a small number of studies, or it was not replicated across studies either. And then data for the remaining anti-seizure medications was either quite limited or lacking altogether. And so I think another important takeaway from this review is that there's still a lot we don't know about the potential effects of these medications on postnatal development.
And I think to pick up something Eliza said too, it's something that we're going to have to keep investigating over the long term, because the nature of a lot of these conditions, the neurodevelopmental conditions and a lot of cognitive disorders, is that they'll only become evident as the children age. And so we're getting an increase. This systematic review is able to contribute to an increasing picture that there might be some issues for certain drugs like valproate and topiramate in children, but we really don't know the long-term effects of these drugs into adulthood. And we know that cognitive development continues well into adulthood. So there is still a lifespan approach that is unfolding in real time with these drugs as well.
Now, you mentioned, of course, that some of the anti-seizure medications showed some mixed findings, and some of the studies that were included had higher level of evidence than others because some studies maybe didn't control for some important influencing factors, such as maternal IQ or family history, things like that. So what do we do with this information now in terms of how do we apply it to our clinical practice?
So I think when we're talking about comorbid factors, we're talking about sort of different maternal characteristics, like possibly their own history of neurodiversity or neurodevelopmental disorders in the family, psychiatric history, exposure to other teratogens during pregnancy, like alcohol and smoking, as well as different socioeconomic factors as well. So I think it's important to mention that there's no perfect study. We incorporated a lot of different methodologies in this systematic review: cohort studies, population-based studies, cross-sectional registry studies, and each study design is able to contribute something different to this field. For example, with the large population-based studies, they're able to provide a large number of exposures to monotherapies that maybe aren't that common. And there's also a low risk of selection bias as well. So you get sort of really objective data in large numbers from these studies. And on the other hand, prospective cohorts can contribute really detailed clinical data and are better able to interrogate the role of anti-seizure medication dosage during pregnancy. So I think there's a place for all of these different methodologies. But on the other hand, I think mixed findings in and of themselves aren't intrinsically unhelpful. While there may be, due to different methodologies, for example, we had a large heterogeneity in terms of outcome assessment methods that sort of prevented us from doing a meta-analysis. But I think the mixed findings are also telling us that there's some kind of underlying mechanism that needs exploration here that's accounting for that. For example, there's probably a genetic vulnerability that means anti-seizure medications affect these women differently. Possibly sort of acting on susceptible genes or altering gene expression, because you could have two women with the same seizure disorder who are taking the same medication at the same dose, and one of them will go on to have a child with neurodevelopmental problems and the other one will have a neurotypical child. So there's obviously individual level genetic factors at play here. The value of this systematic review is to try to get a big picture of that, to sort of cut through some of these mixed findings and able to say, these are the drugs that we have quite a solid evidence base that they are harmful. These are the drugs that maybe the results are inconsistent or, they need replication. These drugs that are comparatively safe. These are drugs we know nothing about. And ultimately, this is to empower our patients to make better informed decisions regarding the medication they take during pregnancy.
And I think that there's good historical context to support that approach, in that, for instance, it was known for a long time about the anatomical birth defects associated with sodium valproate before we were able to appreciate the cognitive and neurodevelopmental effects of that drug as well. And similarly, across all these studies, there has been increasing evidence, again, from the anatomical birth and structural abnormalities for some time, that there might be some concern around topiramate. And I think that is heralding the results of this study here, that indeed there might be some increasing concern behaviourally around topiramate as well. So historically, there is context that from these mixed signals, you start to get a consistent signal that there is something going on with some of these drugs that require further exploration. And that's really the value, I think, of Eliza's systematic review here, is what drugs do we need to focus more effort on, that we need to have more information around when counselling our women with epilepsy who are of childbearing age.
I know you've identified valproic acid and topiramate as medications that probably have some worse developmental effects. A question, though, is what if a patient with epilepsy comes to you, but she's already 12 weeks pregnant on topiramate or valproic acid? Is there a window of time where changing the anti-seizure medications could potentially prevent the neurodevelopmental effects? Or is it similar to, what we think about neural tube development that occurs early on? Do you think at maybe 12 weeks or by second trimester that the effects have already happened, or is there time to make a change?
I think you touch on a really important clinical issue that a lot of neurologists would come into contact with, is that during pregnancy, the risks to the neurodevelopment of the fetus in terms of resulting from the exposure to anti-seizure medications must be balanced against the risks of seizures during pregnancy to the mother and the fetus. So you sort of put in this conundrum where you've got to balance the risk of seizures to the potential and a lot of the times the unknown effects of these medications on postnatal development. I think, like you mentioned, neural tube structural formation during the first trimester is potentially one of the areas in which these drugs like sodium valproate may have the greatest effect. There's some evidence from studies such as MONEED that third trimester exposure may be associated with the highest risk of adverse outcomes, possibly speaking to affecting synapse formation in the fetus, for example. But those kind of variables were not sort of scrutinised in detail in this review. The impact of seizures during pregnancy and trimesters of exposures is looked at quite in detail in the major congenital malformations research, but it's not routinely scrutinised in neurodevelopmental outcomes. So I think that's another avenue for investigation as well, and one that MONEED is looking at in a lot of detail.
And then, of course, we don't have a lot of great information on some of the newer anti-seizure medications, which are becoming more widely used. Is there anything being done to try to gather more information about those newer drugs?
Yeah, definitely. And when we're talking about the newer generation agents, we're speaking about drugs like zonisamide, lacosamide, perampanel, brivaracetam. So there's ongoing prospective cohort studies. Like Jen mentioned a few of them earlier, the North American Anti-Epileptic Registry, the UK and Ireland Pregnancy Register, the Australian Pregnancy Register, And these studies continue to enroll pregnant women taking various medications. So that sort of speaks to that this is a continually evolving field. We also have population-based registries that are always accumulating this information, and they're regularly analysing it as well. And so I'm speaking about more of the large Scandinavian databases as well that record this information from birth. They'll periodically come out with their outcome data in a few years' time. But I think we need new ways of collaborating and investigating these outcomes. And this possibly might be creating standards of assessment so we can have consistent methodologies to enable cross-country, cross-discipline collaborations. Because one of the things we identified in this systematic review was that there was a real lack of data coming from psychiatric populations, even though we know that a lot of people who take anti-seizure medications take them for non-epilepsy indications. So I think that's another area as well that we need to draw more attention to going forward. And like Jen sort of mentioned earlier, we do get a signal from birth about the teratogenicity of some of these drugs. For example, the URAP data found a few years ago even that topiramate was associated with an elevated risk of major congenital malformations. And now we can see in this systematic review that this teratogenicity extends to neurodevelopment as well. So although the neurodevelopmental outcomes sort of take some time to accumulate, we can get some signal from birth as well.
And I'm glad you brought that up about, these anti-seizure medications being used in other populations other than epilepsy. And I think that's really highlighted well in the paper where you do tease out like whether, actually the epilepsy itself or the anti-seizure medication, like what do we know about how much one is playing into it versus the other?
We know that women who have psychiatric disorders are at higher risk anyway of having offspring with neurodevelopmental conditions and are potentially going to require more support over the lifetime of their children to support these children and their needs. As Eliza revealed, there was a real dearth of information around the psychiatric indications for some of these prescriptions.
And I think it's a good reminder if you have a pregnant patient on an anti-seizure medication to remember to recommend to them to enroll in one of the registries as well. Is there anything else we should know about anti-seizure medications and neurodevelopmental outcomes?
Well, I think we touched on about the potential for genetic contributions, and I think this is a really exciting avenue for future research. Kimford Mehta, says that all anti-seizure medications are teratogenic to some degree. They act in a dose-dependent manner. So why are some people affected and some not? So again, we're speaking about potentially genetic vulnerabilities. So in the future, it would be fantastic to incorporate genomic analyses with deep clinical phenotyping to help possibly identify genetic predispositions or enable a deeper investigation into the pathogenesis, like we were mentioning earlier about trimesters of exposure, and also looking at the longer term outcomes as well. As Genevieve mentioned, we had a lot of data in early childhood. Some were conducted up to adolescence, but it's really quite unknown how this manifests in adulthood. So I think extending the window of exploration into these effects will be really useful in the future. And do you want to speak to the final point, Jen, about clinicians' involvement?
A really important thing that, Eliza, your systematic review revealed was that it really encourages us to reflect on the huge importance of the prescriber-patient relationship. And we know that women with epilepsy have a lot of anxiety around the impact of these anti-seizure medications on their unborn child. And so we really encourage the clinicians to take time to develop that trustful rapport with your patient so that your women with epilepsy feel comfortable coming to you and having these conversations around the relative risks and benefits of the different drugs so that our patients are empowered to make informed decisions about what drug is best for them in terms of their own health, but also the health of their potential or unborn children. So a clinical take-home, in my view of Eliza's paper here, is that we ourselves need to make sure we're across all the structural risks associated with these drugs, but also the longer-term neurodevelopmental and cognitive risks of these drugs so that we are best placed to help these women with epilepsy and to talk them through their anxieties so that they feel comfortable being on these medications over the long term.
And I think that's a great message to end with too, is just that reminder to talk to all of your young women of childbearing age about these things before they become pregnant, and try to counsel them that you would like to be involved in the planning in case medication changes are needed before pregnancy, because that's where we can actually be the most help. So if you can find more information in the article, which is titled Neurodevelopmental and Functional Outcomes Following In Utero Exposure to Anti-Seizure Medications, a Systematic Review, and that is available online now or in the April 23rd print issue of Neurology. Genevieve and Eliza, thank you so much for joining us today.
Thank you so much for having us.
Thank you.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.